Would you like to work closer to home, save money on gas, and be rewarded for your hard work and attendance? Then Bellisio Foods is looking for you. That's right, Bellisio Foods is now hiring for multiple positions and shifts with great employee benefits, an on-site health clinic, competitive wages, and advancement opportunities. Bellisio Foods is a company that truly values their employees. Apply online at belisiofoods.com/careers.
The Jackson County Fair Board, in conjunction with Total Media, proudly present Neil McCoy. Neil McCoy. Saturday, July 15th at the Jackson County Fair. VIP track access seats now available for only $30, which includes admission to the fair. Get tickets now at jacksoncoohfair.com or at the Total Media Studios in Jackson.
Good morning, everyone. Happy Monday and welcome to the morning show. Beautiful start to our work week. And of course, we have one of our favorites here, a doctor from Holzer, and we're going to talk about all things women today, women's care.
That's right. Yeah, thanks for having me.
Yes, of course. And so Dr. Robert Bowers is here, and you are, I think, specialize in obstetrics and gynecology.
That's right.
Let's just say OBGYN for short.
Yeah, we'll just get out of the way. It's obstetrics, gynecology. Last time we have to say it.
Okay, good. All of that. He's a girly doc.
That's right.
No, welcome to the program. And we're so happy to have you here today because we're going to talk about, women's health and the fact that, the important things that we need to do. Unfortunately, none of the women's health things are very fun for us women, but it's so important.
It is. It's really important. None of it is a picnic for sure. Mammograms kind of uncomfortable. Pelvic exams, definitely kind of uncomfortable. Clinical breast exams, all that. Not the most comfortable stuff, but important to do regardless. So.
That's exactly right. And, we women put it off. We do the things that women do, and we can't do that. And we're going to tell you why today.
That's right. That's right.
Yeah. And so you are working at Holzer. You've been there
That's
for how
right.
long now?
Oh, my gosh. I've been there. It'll be 2 years in July, which has flown by.
Yeah, can you believe it?
No, I can't.
And are you working in all of the locations or?
So I don't go to the Athens location, but I do go to the Gallipolis location mainly, and then I do 1 day a week in the Jackson location, and then a couple days a month in Proctorville, the Lawrence County location.
Oh, okay.
Yeah.
Awesome. Very good. Well, I'm sure they're happy to have you there.
Yeah, happy to be there.
So Marla's here and Amy's here, but Marla was saying that you delivered her little twin babies.
Yeah,
and we were asking, we were kidding, and we were like, did you play football? And he's like, yeah. And we're like, okay, it's kind of the same thing.
Yeah.
Just carrying.
No, well, I was a center. I played at Marshall, actually.
So it set you up for success there.
It's like I'd been practicing my whole life.
Just catch it, toss it.
That's right. That's yeah. A little bit simplified, but yeah, pretty much.
All right. Well, all kidding aside, it is very, very important that we talk about women's health because I think just in generalities, women tend to put their health care to the side when they're dealing with their kids and their husbands and their family members and all of that, and then don't have time for their own needs.
I couldn't tell you how many times women come in for their annual exams and they're like 42 and 40, 45, whatever, and they're finally kind of like empty nesters and they haven't been to the doctor since they delivered, basically.
Yeah.
Just life gets really busy between, school, sports, keeping the kids fed, keeping the kids vaguely clean.
Working, all that stuff.
Yeah, absolutely. And it kind of takes a back seat. But it's important that you not let it do that. In addition to your self-care that you do as far as your mental health. So taking some time, maybe I have a patient, she loves going to get her nails done. That's her self-care.
Yeah.
Right.
Sure.
When she's not working, if she's, got a little bit of time, she goes to the nail salon, and her nails are always on point. They are nice. But
Sweet.
yeah, in addition to that self-care, taking care of your mental health and your well-being, you got to remember about your physical health as well. And so it's very important that you keep your annual well woman exam. And there's a lot of different reasons for that, but we can kind of delve into that if you want to.
Yeah, I mean, and listen, women are caregivers by nature, and but you can't care for others if you're sick yourself. So, you got to make sure you care for yourself first before all of that other stuff.
That's a fact.
Yes, absolutely, and well, we'll get to that in just a minute. But all right, so let's talk about. I think the first thing we wanted to talk about was kind of like the pregnancy part of that. Let's get into that.
Yeah. So that is a very important time for women's health in general, because most of the time, if women are taking care of somebody else, like a baby that they're carrying, they're gonna show up to those appointments, and you're gonna be at the doctor a lot during your pregnancy. So it's a really important part of women's health care. And we at Holzer, we actually have kind of an interesting setup in that we have a prenatal nurse. Yeah, her name's Dawn. She's spectacular. She spends like an hour and a half with, new pregnancies. Basically, when they come in, they've had a confirmation of pregnancy, they're definitely pregnant, and they want to establish care with us. Dawn spends like an hour and a half talking to them.
Nice.
About,
woman to woman.
Yeah, that's right. She talks to them about, the importance of breastfeeding, the importance of genetic screening for things like Down syndrome, Edwards syndrome, Patau syndrome, a handful of other things that we can screen for. And she just kind of generally runs through their past medical history in significant detail to make sure that we're not missing anything. And it's a great time that if we have missed something, we can kind of get caught up with that.
Yeah. And I mean, there's so many, genetics do come into play with some of this stuff. And so, it's very important to know your whole history and, your partner's history and all of that stuff, just to make sure baby's going to be okay.
Absolutely. I had a pregnancy where they finally, like, towards the very end of the pregnancy, they were like, oh, by the way, he had a major cardiac defect when he was a baby. And I was like, you should have told me that. Yeah.
That's kind of nice things to know ahead of time.
I mean, this was a long time ago. This wasn't even here, but it's like, you probably should tell us about that stuff. So that's why it's important to get in with Dawn, because this wasn't even here, so we didn't have Dawn. And she really is great about finding that stuff out. So
very good. And sometimes it's, no offense to you dudes out there that, but sometimes it's easier to just spill to a woman.
Yeah. No, that's absolutely true. Absolutely.
Not that he isn't precious, because look at this. He is such a sweetie. Okay. So when you think about pregnancy, there's I don't want to get pregnant, and then there's I do want to get pregnant, and then there's I'm trying to get pregnant but can't get pregnant, and there's all of this stuff surrounding pregnancies. Could we delve in a little bit to all of those situations?
So let's start with I don't want to be pregnant.
Yeah.
That's a huge issue across the United States, is unintended pregnancy. People that aren't either, financially ready for a pregnancy, or just, at a stage in their life where they're not ready for a pregnancy.
Sure.
An ounce of prevention is worth, a pound of cure as far as that goes. And contraception options are becoming better and better and more widely available. And just to kind of run through what those options are, you've got short-acting options, and you've got long-acting options.
Okay.
Yeah. So the long-acting options are called long-acting reversible contraceptives, and they're really, really growing in popularity.
I could see that.
Yeah. So it's much less labor-intensive to remember, I have to take a pill every day, or I have to do this every day. And those long-acting options include intrauterine devices, so IUDs.
IUDs, yep.
There are IUDs that have hormones. There are IUDs that don't have hormones. The ones that don't have hormones, it uses copper. The one that's on the market is Paragard is the name of it. And it's actually good for 10 years. Yeah. So if you're not looking for, if your 10-year plan doesn't include pregnancy, it's a very, very effective contraceptive.
Well, let me ask you, so can you explain to our viewers how an IUD works?
Absolutely. So an intrauterine device is exactly that. It sits inside of the uterus and prevents pregnancy one of two ways. If it has hormones, the progesterone in that IUD, that's the hormone that it contains, kind of helps to thin out the lining of the uterus, kind of helps to thicken some uterine fluids so that things can't swim through the uterine fluids. Yeah.
Those little pesky swimmers.
Those pesky swimmers can't break through that wall. So, and then it also is a really good option to control heavy bleeding and stuff like that. So that's something we don't talk about a whole lot.
You know, and so a lot of folks out there, whether it be religious reasons or whatever it may be, kind of might frown upon contraception, but it can also be such a huge tool in women's health, whether it be, you know, what would be some of the reasons why it might not even be to prevent a pregnancy, but it could be to help you with other things?
Absolutely. So one of the main reasons that I end up seeing patients during, you know, contraception care type visits, they have really, really heavy periods, or they have really, really painful periods, where their periods are too irregular, too infrequent, too frequent. And the mainstay of therapy to kind of control those things is going to be hormonal therapies, including birth control pills, the birth control patch, the birth control ring, the progesterone-containing IUD that we talked about.
Sure.
There's also a progesterone implantable device that goes in your arm.
Okay.
It's called Nexplanon, and it lasts for 3 years
Okay.
for contraceptive purposes. And then there's also the contraception shot, Depo-Provera. That's
okay,
good.
you hear that a lot.
Yeah, every 3 months you get a shot. Yeah. But all those hormonal options, in addition to being effective ways to prevent pregnancy, are really effective ways to control menstrual cycles as far as if the timing is irregular, if bleeding is too heavy.
Okay.
And they're very, very effective at doing that.
And let's just be honest, you know, life's hard enough. And when something like that is going on, as a woman, like that is just... it is just something that kind of like consumes your life for a minute, and you just don't have time, and it's, you shouldn't have to go through that.
It's so more and more often we are trying to achieve what's called complete menstrual suppression in patients. We're finding that there is no medical reason that you have to have a period every month.
Really?
If the doctor is giving you medicine to kind of help and stop the periods, then you don't have to have one every month. Very, very commonly, there are birth controls that are 3 months at a time, so you end up having like 4 periods a year.
Oh.
A lot of other options can completely suppress periods altogether.
Okay. And that's not a bad thing. That seems to me like the circle of life, you know, thing should be.
No, it's actually really, really safe.
We're stricken with our monthly visitor.
I know. No reason you have to have a visit from Flo every month.
Okay.
Fair enough.
Yeah, fair enough.
But it's actually protective against things like ovarian cancer and endometrial cancer, to suppress those cycles if you're doing it with medications. Now, if you're not having periods because you're just not having periods,
then you might want to get that checked out. That's
not right. Yeah. So there's a lot of different things. You know, polycystic ovarian syndrome can cause that. That's a super common problem that we see across the United States.
So I hear a lot of, I've talked with a lot of people lately about ovarian cysts. I don't know what that is exactly, but, and I hope I don't get one because it sounds horrible.
Yeah.
But why is that so common? And what is it exactly?
It's super common because that's what the ovaries normally do. There's this misconception that an ovarian cyst is 100% of the time an unnatural, irregular thing.
Okay.
So just monthly, someone who is cycling normally, they're going to develop an egg. The egg's going to grow into what's called a dominant follicle. And that dominant follicle is what's going to be ultimately the egg that gets ovulated. Okay. I like to use the analogy of queen bee and worker bees.
Okay.
The egg is the queen bee.
Mm-hmm.
The worker bees are these fancy cells called granulosa and theca cells.
Mm-hmm.
And they support the egg until it gets ovulated. And then after that egg goes, that's what it sounds like. I'm just kidding. I'm just kidding.
Don't you hear that every month?
Yeah. What is that?
Now you know what that noise has been all the time.
After the egg gets ovulated, the leftovers to support the worker bees,
Okay.
those granulosa and theca cells are left over, and they typically form what's called a corpus luteum. And that is what supports a pregnancy early on. Before there's a placenta, before there's a baby, when it's just a ball of cells,
Mm-hmm.
the corpus luteum is what produces progesterone and lots of other hormones to help support and grow that pregnancy.
Okay.
So that's something that's supposed to happen every time you ovulate.
Gotcha.
And sometimes that corpus luteum sticks around and forms what's called a corpus luteal cyst.
Aha.
So sometimes on ultrasound, if we see a small cyst, usually we're talking like the size of your thumbnail,
Mhm.
give or take, that can be just a normal functional component of the ovary.
Your body's doing what it's supposed to be doing.
Right.
Okay.
Now, sometimes if they're sticking around and they're causing pain, or if they get large, like more than 4 centimeters,
Mm-hmm.
so, about the size of like your 2 thumbs put together,
Mm-hmm.
then we start to kind of wonder, okay, is this something additional? Is this like an actual ovarian cyst that shouldn't be sticking around? This isn't just something functional, normal function of the ovary. And those can be, most commonly benign processes,
Mhm.
but on rare occasion in the right age group, it can be an indicator of something as severe as ovarian cancer.
Okay.
Now, not telling everyone that has an ovarian cyst you have cancer. Okay.
No,
It's
not at all.
super rare. It's like a risk of 1 in 75, which translates to like 0.4% or something like that. Don't do the math because I didn't do the math yet. I don't math. But it's a very, very low risk that something be actual ovarian cancer. But it is important to follow these cysts because there are other risk factors, like sometimes they can bleed.
Mm-hmm.
Sometimes they can cause the ovary to twist. That's called ovarian torsion.
Oh.
Yeah, that's an emergency. So what we typically do is we follow them with ultrasounds and make sure that they're either resolving
Okay.
or not growing, continuing to just look like a simple thin-walled ovarian cyst. And if we need to do something about it, then we can.
Cool.
Yeah.
So this is again why, as women, you should go get checked out.
That's right.
Yeah, and do your yearly stuff.
Yeah.
Okay, so we talked about that part. Well, I'll just let you lead. You're good at this.
Yeah. So we talked about preventing pregnancy.
Yes.
Then a lot of times you have patients that want to be pregnant
Mm-hmm.
that can't get pregnant.
Mm-hmm.
And we've touched on this once already, talking about, irregular cycles, but polycystic ovarian syndrome is a super common reason that people are unable to become pregnant because you don't always ovulate when you have PCOS. And it's really multifactorial. And we don't have anywhere near enough time for me to go into details of PCOS. I could wax poetically for hours on end about PCOS.
Sure.
But long story short, if you're having really, really irregular cycles, far too infrequent, then you need to get in and see the doc because it may be, could it be PCOS? Could it be something else?
Sure.
Another super common reason that patients are unable to achieve pregnancy would be like endometriosis.
Yeah.
This is a hot button word here. You hear endometriosis, everybody's like, "Oh, my mom has that. My sister has that."
I feel like I feel like that's probably self-diagnosed a lot too.
A lot.
So could you explain exactly what that is?
Absolutely. Endometriosis is when the lining of the uterus is anywhere that it's not supposed to be. It's supposed to just be inside the uterus. The fancy doctor word for the lining of the uterus is the endometrium. Hence, if you have endometrium, places it's not supposed to be, that's endometriosis. Now, there are 2 functional theories on how this happens. They both have a genetic component, both of these theories do.
Okay.
So it's more likely that you'll have it if your mom or your sister had it. One is that when you get your period, it can go backwards out the tubes.
So I had a doctor explain this to me once, and then I said it to another doctor, and he said I was insane.
No.
Okay. So that is a thing.
Absolutely.
Like reverse menstruation
Yeah,
is what he called it.
retrograde menstruation is the fancy doctor word.
Well, I'd like to go back to the doctor that said I was crazy. Yeah, smack him around a little bit.
Smack him around a little bit. Sometimes we need it. But that's the first functioning theory about how endometriosis happens.
Okay.
There's another functioning theory, and that is that it happens when you are developing as a fetus. The lining of the uterus kind of loses its way as you are developing as a little bitty baby.
Oh, as a little bitty?
As an embryo.
Oh,
yeah.
okay.
And
so you're born with it.
Yeah, and it ends up in weird places. Like, you can have endometriosis in your lung, right? How would you get...
Marla just fell off the chair.
What? No, how would it get to your lung
how
if
does it
it's
get
retrograde menstruation, right?
Right.
So that's why there's kind of two functioning theories behind endometriosis right now. That the lining of the uterus ended up there as you were developing as an embryo, and that's just kind of where it sat.
You know, and it's so interesting with all of the modern medicine in the world that they still don't know about this. You know, it's kind of wild.
That's one of the reasons I love obstetrics and gynecology is because things like everybody's probably heard of preeclampsia, right?
Mm-hmm.
Preeclampsia is something that your blood pressure goes crazy in pregnancy specifically. You get really swollen. It can go really, really poorly and have really bad outcomes. We're still not completely sure why.
Yeah.
We have a pretty good idea, but we're still not completely sure why. So it's a really cool field to be in.
You know, it would be. And it's like, I know, for example, I have a family member who is, and I mean, the healthiest human being I know. She eats twigs and berries and, you know, hikes and does all the things that you're supposed to do. And in both pregnancies, developed gestational diabetes. And it was horrible for her. And you're just like, what?
Yeah,
Why?
it can happen.
Like,
Yep.
what does she do wrong? She doesn't do anything wrong.
Pregnancy is an awesome stress test for the female body.
Yeah.
It's like a 9-month long stress test.
It would be.
It tests your heart. It tests your lungs. It tests your pancreas. Everything.
your mental
Your
state.
mental health.
Yeah.
No, it's. I don't know how you all do it. My wife did it 3 times, and all 3 times I was like, I don't know how you're doing this. So,
no, it is definitely a marvel of well, the human body itself is just insane. If you honestly stop thinking about it, because if you think about how your body's functioning, it will like blow your mind and it will like freak you completely out.
yeah, man.
Yeah, it's like trippy.
We're getting deep in here.
So deep.
Yeah.
So, all right. Well, let's talk about women like me, for example, that are too old now to have kids but never had kids. And the reason I want to bring that up is because there are certain risks involved in that from what I'm hearing from the docs, like higher breast cancer risks or something like that. So, so if you haven't had children, then what?
Well, there is nothing wrong with not ever having kids. Some people, that's just their choice. That's what they want to do. They're like, I don't want to have kids, and that's what I'm going to do. But we do know that, you know, pregnancy is a risk-reducing factor for things like ovarian and breast and endometrial cancer. Mm-hmm. Basically, when we talk about anything where you're not having as many cycles in your life for a good reason, not just not having periods for no reason, but if we're stopping your periods with medicine, if you're not having a period because you're pregnant, if you're not having a period because you're breastfeeding, those are risk-reducing factors for things like breast, endometrial, and ovarian cancers. So it's, you know, even though it's a 9-month stress test for your body, it's also a little bit beneficial as well.
Sure. Absolutely. So, for someone like me, are there more testing that you should do? Is it obviously it's probably more crucial that you get those yearly tests and all of that.
Right. So age-based screening, specifically
because I'm old now.
I didn't say that. I said age-based. Age-based screening for women's health is key. So there's not additional screening that somebody needs if they haven't had children.
Mhm.
They need, at this point, if they are normal risk, they just need routine age-based screening. So for somebody who, let's say, is 40, the appropriate age-based screening for that group is going to be, you need pap smear screening, you need an annual clinical breast exam, an annual pelvic exam, and it is debatable whether or not you start mammograms at 40.
Mm-hmm.
Different societies have different recommendations,
Mm-hmm.
and that's kind of a discussion that you should have with your physician on the risk versus the benefit of starting mammograms at 40.
Okay.
So the risk being mammograms do involve radiation. It's a fancy x-ray, basically.
Okay.
So most society guidelines would say sometime between 40 and 50, you need to initiate mammogram screening.
Okay. And then is that an every year deal, or is it, is it like you sit down with your doctor and come up with a care plan, or every girl should do the same thing, or how does that work?
Right. So specific for breast cancer and breast cancer screening, you need to figure out, are you at normal risk or are you at increased risk? If you're at normal risk, annual screening with a mammogram is appropriate for you.
Okay.
And like I said, it's a conversation with your physician when you initiate screening, but absolutely by age 50, probably by age 40.
Yeah.
You should initiate that, and that's every year. Now, if you have increased risk because of like a genetic predisposition, so
Sure.
things like maybe you've heard of BRCA,
Mm-hmm.
the
The
breast
BRCA
cancer,
gene.
BRCA gene,
Yeah.
yeah. There's 2 varieties of that, but they both increase your risk for breast and ovarian cancer pretty significantly.
Yeah.
And recommendations are very, very different for those high risk patients.
Okay.
So it's going to include things like alternating every 6 months with an MRI versus a mammogram. But we could really get in the weeds on that one. But
Sure.
if you're not normal risk, then you need to really get in with your women's healthcare provider and talk about what needs to be done.
Yeah, and here's the deal, ladies. Be your own advocate. You hear so many times of someone just like, I just don't, something's off, I don't know. And then, somebody says, oh, no, you're okay, don't worry about it. And then,
Mm-hmm.
a month later, it's like, oh, no, there is something wrong. So
Right.
be your own advocate. You have to do the self-breast exams and all of the things. If something feels off or whatever, please say something.
Absolutely.
And you can't wish breast cancer away, I promise you.
No, you
Or
cannot.
any other kind of cancer.
That's
like,
a fact.
You can't. It's not going to go away on its own.
Yeah. Something that is kind of convenient is that breast cancer screening is getting more and more sensitive and specific for detecting it.
Yes.
And it's getting a little bit more comfortable as well.
Yes. And let's talk about your fun, fancy machines that you have at Holzer now.
Yeah. So we have the colloquial term, or the layman's term, is 3D ultrasound, or 3D mammogram, excuse me. 3D mammogram. Like I said, we have fancy doctor words for everything. Fancy doctor word is digital breast tomosynthesis. That's why we just say 3D mammogram. Okay. It's too much.
Yeah. We'll just go with the 3. It's kind of like OBGYN. We'll just go with that.
Yeah. Less of a mouthful. So,
yeah.
But it is very helpful with increasing the sensitivity and specificity of detecting breast cancers, as opposed to just traditional mammography. And kind of the way it works is you take multiple mammograms from different angles, and then the computer is able to reconstruct a 3D image, and it gives radiologists a much more detailed picture of what's going on, as opposed to traditional 2D mammography.
Or it's just kind of a flat picture. This is like all around.
Yes, and it's minimally increased radiation exposure, still well below the FDA recommendation for radiation exposure for a single exam. But it's safe, it's more effective at detecting those cancers, and it is something that we have available now at Holzer.
Yes, very good. And the girls sitting over to my right here, we're talking about, so when I went in October, you guys were just getting the machine, so I didn't get to see the new machine for my mammogram. But the girls were saying that it seems to be a little bit more comfortable. Way more comfortable. Okay.
Yes.
Super. So
Yeah.
that's something, I mean, again, see, like all of our women health stuff is just no fun, but
It's-
like if it's going to make it better, let's do that.
Right.
All the
And-
way around.
Absolutely. So yeah, it's supposedly it's a lot more comfortable, and it's not as much compression required as a
Okay.
traditional flat 2D mammography.
Okay. And let's just talk about it and be honest that, there are men that can
Yeah.
get breast cancer.
Yeah, absolutely. That's actually one of the 4 questions that I ask at all annual screening exams is any men with breast cancer in the family, because that puts females at a significantly higher risk to be carriers of like BRCA and things like that.
Really?
Yes. So I always ask 4 questions. History of female breast cancer in your family less than 40, male breast cancer, history of pancreatic cancer, or history of ovarian. And that kind of is a quick triage for who needs maybe more genetic testing, because they have a predisposition for those various cancers.
Makes sense. And then
yeah.
you can refer them over to the
Mhm.
to the testing and all of that stuff. So I was thinking about some of the other cancers that you've mentioned, whether it be like ovarian cancer or that kind of thing. Breast cancer, you can feel a lump. It's we all do the self breast exams and all that stuff. How do you know that you have something that's like an internal kind of thing?
Well, that's actually a very, very good question. Ovarian cancer is kind of, among obstetricians, gynecologists, colloquially, the silent killer. There's
Oh
no,
man, that sounds bad.
There's no effective screening.
Right.
There's really no way to know. There's not a ton of early signs. And so when we do find out, it's usually at a pretty later stage. Because you feel bloated, you have loss of appetite, you're losing weight, but you don't know why. So yeah, ovarian cancer it's a bad deal. It's
Okay.
a really bad player. Now, other gynecologic malignancies like endometrial cancer, that one usually presents pretty early at a low stage, low grade, with abnormal bleeding.
Okay.
Yeah, typically it's going to be in postmenopausal patients. That's kind of the major age group, and they have postmenopausal bleeding, and we can usually identify it and take care of it pretty effectively early on.
Okay.
But even better than identifying and treating endometrial cancer is cervical cancer. That is the one that we're rock stars at that one.
Yes, that's why you go get that yearly
you get your
pap
pap smear. Yeah. So we're actually going to talk about that yearly thing as well. Might be able to space that out for you a little bit. Yeah. So the most effective screening program in the world to date is the pap smear screening program for cervical cancer.
Okay.
Recommendations typically come from the major governing body, the ASCCP, and they changed in the last 4 years. And so HPV testing is very, very important for your pap smear after a certain age. HPV is human papillomavirus. There's dozens and dozens and dozens of types of HPV. HPV 6 and 11, those are the ones that cause good old-fashioned warts that you get on your knuckles or your knees or wherever. 16 and 18 are very high-risk subtypes for cervical cancer. And then there are several other high-risk subtypes of HPV, 31, 33, 45. There's about another 24 of high-risk subtypes. And those are the things that you check for when you do HPV testing with a pap smear.
Okay.
So when it's time to get started with your pap smears, typically we don't do that. We look at the cells specifically. That's called cytology.
Okay.
What the cells look like under the microscope. And then when you reach an appropriate age, we start with HPV testing.
Okay.
So,
we'll hold that thought because we have a message from our friends at the Vinton County National Bank, and then we'll be back and continue our discussion.
At Vinton County National Bank, we believe in supporting the areas where we live and work. Now, we'd like to honor those who also serve our communities. Our new Community Champions account is especially for first responders, veterans, active military, and anyone employed in the fields of healthcare or education. This account offers rewards, discounts, and other benefits to those who give so much to others. Vinton County National Bank, rewarding those who serve.
All right, and we are back. And again, Dr. Robert Bowers here from Holzer, and he is an OBGYN. We're talking about all things women's health today.
That's right.
And we're having a good time doing that, even though some of the subjects are a little bit weird. But we were talking about HPV, and is HPV something that's sexually transmitted, or is it something that could just be within your body naturally?
So there's typically two ways to contract it. The most common way is sexually transmitted.
Okay.
Other ways, close human-to-human contact. So, there are absolutely, recorded events where a mother who is HPV positive is able to pass that along to an infant during a vaginal delivery. That's not super common. It's not a reason not to have a vaginal delivery. Not a reason not to have a vaginal delivery.
We'll talk about that in a minute, too.
But that is definitely a route of transmission.
Okay.
So the most common way, though, is sexually transmitted.
Okay, because you hear about that. And, like growing up, I know that there's now, a shot for that?
Yes.
And I don't think that existed when I was of that
age
a few years ago.
It was probably like right after you were of that age. It was probably maybe like 5 years after that. But yeah, it's very effective. It vaccinates against multiple strains of HPV. It's called Gardasil.
And you just think about how many then young girls are not going to have to worry about.
Right.
At least that part of it,
Yes, and it has been around for decades now. It has been proven to be a safe vaccine. It is universally recommended. Except in a few very specific indications that are very rare. So if you are somebody with kids and you're like, do I get them vaccinated for HPV?
I know. I've heard that discussion a lot, like, I just don't know. It's just another vaccine, it's just like,
We resoundingly, pediatricians and OBGYNs recommend especially getting your younger female patients vaccinated against HPV, but also males. Males can take the HPV vaccine as well.
Well, it makes sense because it's like, why do we women have to do everything?
I know. Well, the dudes are the ones passing around to everybody anyway. They're all asymptomatic. So, yeah, it's no fun. But no, definitely HPV vaccination is a go. It's recommended, and you should do that.
Okay, very good. And just wanted to get that out there because there is a very simple way to prevent that and seems like to prevent a lot of future problems.
Yeah, and it's very effective and prevents a lot of future pain and suffering, basically.
Yeah.
So.
Okay, very good. All right, so we've talked a little bit about I'm so excited about this 3D mammogram thing. It makes me want to go get one just for fun.
I don't know, maybe.
Well, you think though, but seriously. You think about, women, you hear of dense breast tissue and all this stuff, and it does make you feel a little bit better if you can go in and get a better picture of what's going on.
Right, and that is something that
peace of mind.
Yeah. 3D mammogram can help you with that. If you're somebody who your mammogram comes back every year and the radiologist read it as dense breast tissue, need additional imaging or whatever, 3D mammogram can help with that some, but only to a point.
Okay.
If you have extremely dense breast tissue, almost universally they're going to recommend additional imaging. And your two options there are going to be breast ultrasound, like a whole breast ultrasound. Or breast MRI. Typically, we're not going to order an MRI unless you have really high risk for predisposing risk factors for breast cancer. So typically, if you have very dense breast tissue, you follow up with a breast ultrasound. It's typically going to be done by a sonographer. They just kind of take a few images with just a normal ultrasound probe, like when you get an ultrasound for pregnancy.
Yeah.
There are a few major academic centers that are using automated ultrasounds now.
Really?
Yeah, it's literally just like a computer robot just controls the images taken by the ultrasound. But no, by and large, what's available nationally is going to be just a traditional whole breast ultrasound.
And it's, again, just your own body, right? So if something starts to look weird or gets bigger or smaller or changes or whatever, just say something about it.
Absolutely.
Because it's not normal.
No, yeah, say something. So
Absolutely. All right, well, let's talk about the most fun thing when it comes to OBGYN care, and that's delivering those babies, right? Having babies, how fun.
Yeah.
This, as Marla's sitting over here that just delivered twins. Was it fun, Marla? It was a blast, she said.
They play really cool music in the alarm.
They played cool music?
Yeah.
So you actually delivered Marla's twins. That's so exciting.
Yeah.
And so I think that's just a neat thing. But what kind of music were they playing?
One was Backstreet Boys that I remember.
Yeah.
Okay.
Yeah, a little bit.
And then some AC/DC.
Some AC/DC, yeah. Heck yeah.
Might have had some Greta Van Fleet, not sure.
Yeah. Okay.
We kind of run the gambit.
Yeah.
So, no, that's
Culture.
that's right. No, we like to joke, but seriously, when we're in the delivery room for like a cesarean delivery, we try and keep mom as cool and relaxed as possible.
Sure.
Play some tunes. I always ask, "Hey, mom, what do you want to listen to?" Unless they say like something silly like, "I want to listen to Tibetan throat singing." I'm gonna play it.
Hey, there's an app for that somewhere.
I'm sure. But yeah, that's kind of one way that we try and make it more comfortable and just kind of more laid back for cesarean deliveries, because it can be kind of a nervous time for mamas.
Sure, absolutely. Number one, you're delivering babies, but you're doing it via surgery, so that's never a lot of fun.
No.
So, okay, let's get into the cesarean delivery versus a vaginal delivery. And you hear now of women just being like, "Oh, I just scheduled it," or whatever. But I would think for the most part, just doing it the old-fashioned way is probably the best for everybody.
That is resoundingly the recommendation.
Okay.
Yeah, it's safer for mom, safer for baby, quicker recovery for mom, and very rarely are we going to do an elective primary cesarean delivery.
Okay.
That's where mom comes in first pregnancy and says, "Hey, I don't even want to try. Let's go straight to C-section." It's not as common. I'm never going to look a patient in the face and be like, "No, you can't do that." That is your decision, ultimately, if that's what you want to do. But certainly we're going to counsel you and
Let's talk about this a little bit.
Yeah. So resoundingly, the recommendation from the American College of Obstetrics and Gynecology, or ACOG, is for an attempt at vaginal delivery unless there's an absolute contraindication. So,
Okay. What would be the reasons for doing a C-section?
So if we go straight to C-section, there's not a ton of reasons that we would do that. A lot of times if you've had multiple prior C-sections, we're going to go straight to C-section for a repeat C-section.
Okay.
If it's your first one and we're going straight to C-section, no trial of labor, it's going to be for just a few indications, really. If the placenta is in the wrong spot down by the cervix, baby can't come through the placenta. That's called a placenta previa. You go do a C-section.
Okay.
If the baby's blood vessels are running across the cervix, which is a thing, the umbilical blood vessels can run right across the cervix.
How do you know that?
Ultrasound.
Okay.
Yeah.
You can see it.
Right.
With the okay.
Yes. It's called a vasoprevia. Yeah.
Scary stuff.
Yeah. Vasoprevia is very scary. And we go straight to C-section for that because you don't want baby coming through its own blood supply on the way out. That would be bad.
Yeah.
If mama has HIV with a viral load greater than 1,000, then we go straight to C-section. Or an active genital herpes outbreak. Those are the major reasons.
Okay.
Yeah. There's a handful of other reasons that you run into that you would go straight to a C-section, but they're much less common. Now, if you've had a trial of labor and it's time for a C-section, typically there's only a couple things that have happened. Number one, baby's not tolerating labor. The baby's heart rate doesn't look good.
Not handling it well. Yeah.
Right.
Okay.
And we're too remote from delivery to tolerate the baby looking like that.
Yeah. We got to get that baby out.
Right.
For sure.
Another reason would be if you've been in labor for a long time and nothing's really happening. So typically there's a few steps that you go through before you get to where, baby's not coming out that way. Typically we'll do some interventions like breaking your water. We do some things called internal monitors. And if you've got adequate labor, your contractions are good, you're doing great, but baby's just not coming down, then it might be time for a cesarean delivery.
Okay.
And then otherwise, if there is a significant health problem that develops with mom,
Sure.
would be another reason.
Yeah.
So things like severe preeclampsia that were remote from delivery, mom is just getting worse and worse. She has a super severe form of preeclampsia called HELP syndrome. That's where, you have a high risk of bleeding really, really badly. So those are kind of the three major reasons during labor that you would end up at C-section.
Okay. But that's not, so yeah, you hear about I'm just going to schedule it and go on in and whatever. It just seems to me like, the good Lord made our bodies to do whatever they're supposed to be doing. And if you can do it the old fashioned way, it seems like it would be best for everybody.
Yeah, that's definitely the recommendation.
And then there's, I'm going to have a natural birth versus give me the drugs.
Right.
So, and that's something that I would assume that you would counsel folks on as well.
Absolutely.
Or there's I'm going to do a natural birth until give me the drugs.
Yes.
Give me the drugs.
No, definitely. We like to use the terminology unmedicated delivery.
Okay.
Very high and mighty.
Unmedicated delivery.
Unmedicated delivery, yeah, because all deliveries are natural, but
Sure.
If you want an unmedicated delivery, that's absolutely reasonable if that's what you want to do. Sometimes it's not a choice. Sometimes you come in and you're 10 centimeters and it's time to go. And
I had a friend that did that. She's on a bike ride, and then she's like, I'm good. And then they barely made it in the door of the ER.
Yeah, no, those are always those are always an adventure because it's invariably it happens to somebody that wanted to get medications and they're just not mentally prepared for that, because someone who comes into things saying, I'm not going to get an epidural, I'm not going to do any IV pain meds, none of that stuff, they are mentally preparing themselves for that. But then somebody hits the doors and they had wanted an epidural and it's just like, oh boy.
Well, there's just not, hey, listen, the human body is a miraculous thing, right?
Yes, it is. But if you do want meds, there's no judgment there.
No judgment.
Yeah. I for all three of my wife's deliveries, I told her, look, there are no heroes in this room. When you're hurting, get what you want.
Yeah.
And is it possible that getting an epidural can slow labor a little bit? Yes, it's possible, but it's not so substantially going to slow labor that you're putting yourself at risk.
Okay.
So those are, as far as during labor, if you want meds, the major things that we do, IV pain meds early on, not close to delivery because we don't want baby to be all blah.
Yeah.
Epidurals. So that's a little tiny, looks like a tiny little drinking straw. Goes in your back, feeds medicine in.
Okay.
Epidurals don't run out. You just change the medicine bag and more medicine goes in.
Okay.
Something called an intrathecal. That's where that's just a one shot, boom. They don't leave a little straw in your back. We call it a catheter. And then there's a spinal, and that's typically what we would do for like a cesarean delivery.
Okay.
So those are the major types of meds if you're going to deliver. Some major academic institutions and larger hospitals do nitrous, like laughing gas. Yeah. And so like when mom,
I bet you'd hear some weird things in the delivery room
mom,
if you did that.
Literally the mask is sitting next to the bed. Mom starts hurting and she's just like, okay. And then she's good. But yeah, that's something that they offer at larger delivery centers, larger hospitals. And I've never been part of that, but I imagine it's a really good time.
I mean, we've all seen the wisdom teeth videos, right? So
Oh,
same
yeah.
thing.
Same idea.
Same
Yeah,
thing.
for sure.
Other than having a baby, bringing a human into the world
Right.
while you're doing that.
Right.
Okay. That could get interesting.
For sure.
For sure. Absolutely. Well, geez, we've been talking about all kind of fun things and about how many babies you think you've delivered over the years now. Do you keep
Gosh.
count?
No, I don't. I mean, it's in the thousands, I'm sure.
Isn't that so fun?
Yeah, it is. It's pretty crazy. I actually, a baby that I delivered in residency was going into I think first grade this year. It was like at the beginning of residency, and I was like, oh, I'm so old. But yeah, it's pretty crazy.
That would be fun. And it would be so cool to see them, to see all the little ones grow up and whatever.
It's awesome.
That's a hoot.
Yep. And if you come see me as a doctor and I do your delivery, I'm going to want to play the Delivering Babies playlist. I just filled it full of awesome songs.
Okay.
You're going to like it. Just saying.
It's a good playlist.
It's a selling point. I call it the Having Babies playlist.
I love that. So, okay. So back to just women's health in general.
Mm-hmm.
You are an OBGYN doctor at Holzer. Can people just call? Are you accepting new patients?
Mm-hmm.
How do they get to see you?
There's a couple of different routes. You can just call in to the main line for Holzer, 740-446-5000, and say, hey, I want to schedule with a gynecologist for an annual exam or for a pregnancy or whatever. That's a really easy way to do that. You can get a referral from your primary care physician or from whoever you're seeing at the time.
Okay.
And we get a lot of visits that way. Somebody will be like, oh, hey, you haven't seen your OBGYN for a long time.
Yep.
Go see this person. And I mean, that's pretty much all you got to do. So it's as easy as just calling in.
Okay, very good.
Yeah.
And it's very important that you do so because, again, women, we have to take care of ourselves and we can't take care of others if we don't take care of ourselves. A couple of other questions I have for you. Number one, you said you thought you could save me a yearly trip. What does that mean?
Okay. So you still need to see your doctor every year.
Okay.
For your normal clinical breast exam, normal pelvic exam, just to make sure there's no masses or anything.
Okay.
But Pap smear screening guidelines. I'm going to run through them. You can find this information online. It gets a little bit complicated, but for the most part, except for very, very specific populations, Pap smear screening should start at 21 years old.
Okay. That's a little different than when I was younger.
So 21 years old, unless you have some immunocompromising conditions, HIV, other immunosuppressed states. So 21 years old, you start. From 21 to 24, they're only going to look at the cells under the microscope. Okay? And that is recommended every 1 to 3 years. Okay? So I typically, for patients that are 21 to 24, I just tell them, okay, just come back every year because they're coming for an annual exam anyway, and we're only looking at cytology, just what the cells look like under the microscope. From 25 to 29, it's kind of dealer's choice. If you want to just do cells under the microscope and come back every year to 3 years, go for it. If you want to do what's called co-testing, where they look at the cells under the microscope and they check for HPV, then you're good to go every 3 to 5 years. Okay? Then from 30 onward until age 65, they recommend co-testing resoundingly. That's cells under the microscope and HPV testing.
Gotcha.
You don't have to do that. Other options are just checking for HPV alone, just checking for the cells alone. But the time that you get to go between Pap smears decreases if you just look at one or the other. If you do both, you can go as long as 5 years.
Woohoo!
Yeah.
All right, ladies.
Yeah. So that's the ASCCP recommendation is from 30 to 65, every 5 years with normal testing, with co-testing is appropriate.
Okay.
Now, my might get in trouble from Dr. Ritchie for saying this, but I never really recommend going the full 5 just because it makes me nervous.
I could see that. I mean,
Yeah.
I think as a woman, it would make me nervous to wait 5 years.
And you don't know what life is going to throw at you. Do you have, a new partner that maybe your old partner didn't have something and your new partner does, right? So I usually try and stick to that around 3-year recommendation.
Sure.
Some women come into my office and they say, every year I want a pap smear. And that's fine. I'll do it. But we can save you a little bit of hassle and a little bit of discomfort. We don't necessarily have to do that every year if you have normal testing. Now, with normal testing, no weird results, you're done at 65.
No more tests?
No more pap smears.
Okay.
If it's not normal, it changes a little bit.
Okay.
But that's the rules. That's the recommendations.
So we have a few minutes left. So when do we women get into menopause? So this is hilarious because, as you get a little bit older and you meet up with your college girlfriends or whatever, and everybody starts sharing stories about weird things that are happening to your bodies over the years. When does that happen for the typical woman?
So the average age of menopause in the United States is around 51 years and a few months.
Okay.
And that's the average. Some people will be way earlier. Some people will be later. And all that's still kind of within the realm of normal. Now,
and
really,
what exactly is menopause?
Menopause is 12 months, no periods. That is menopause.
Okay.
Now,
and a whole lot of hot flashes in between, right?
That, the doctors have fancy words for everything. Like I said, that's called the climacteric state, right? The approach to menopause or perimenopause. And those years after menopause are all in that climacteric state. And that can be years and years and years. That can be 5 years on the front end, 5 years on the back end, right?
Awesome.
So you're
Can't
talking
wait.
about mood swings, hot flashes, things that are drier than they used to be, changes in your sex drive. All of that is within the realm of possibility for menopausal changes. And
is there hope for us, though?
There is.
Good.
There is a light.
I was hoping you'd say that.
There is a light in the tunnel there.
Okay.
I said this on the radio show earlier, but literally, my mom, at least once a week, she'll message me and she'll say, "You be sweet to those menopausal women. You listen to them," because she went through this pretty recently, and she's just she was kind of hardline. I don't want to do hormones, nothing like that. And I think her physician kind of talked her into some stuff, and life got significantly better.
Good.
But there's a lot of things we can do. The mainstay of therapy, if you're having a really tough time with menopause, is going to be hormonal therapy. People hear that and they retract and they grab their chest. Oh, hormones?
Oh, I don't know about that.
It doesn't have to be an unsafe thing. There are safe ways to do it. Your doctor is going to know, are you someone who is a candidate for hormone therapy? Are there reasons you shouldn't? And they're going to know, okay, what type of hormones are appropriate for you? And how long and what dose should you be taking?
Okay.
The general rule for hormone therapy, lowest effective dose, shortest amount of time.
Makes sense.
But you don't have to be absolutely miserable. Talk to your doctor. There's other things outside of hormonal therapy that can help. But talk to your women's health provider. Let them know what's going on. Let them know that you're absolutely miserable. And we'll try and help you out.
Because once again, as a woman, you want to take care of others. And if you're miserable yourself, it's not going to, that's not going to help the situation. So,
Yep, for sure.
Well, very good. There was one other topic, and we only have a minute and a half to talk, but so I hear a lot of people that are my age, whatever, and be like, "Oh no, I sneezed." Oh God.
That is something that we
don't
can
make
fix.
me laugh, or please don't sneeze, because
don't cough, don't lift that.
Yeah, because you're gonna leak.
Yep, you're gonna pee.
I'm glad he said it.
Yep, I'll say it. Yeah, sometimes
is that
you pee.
normal though, or is it? I mean,
it's extremely common. It's never normal.
Okay. All right.
There are lots of different things that we can do if we're talking about the realm of incontinence. This is the fancy doctor
And
word.
like how abnormal is it to, sneeze and have a few drips come out versus, like, oh God, this is horrible. How do you know when you're in trouble or when you need to seek help?
If it starts to affect your daily life, it starts to affect your decisions, you need to come in.
Okay.
Some women, they have a couple of kids and they sneeze and they leak a little bit and it doesn't bother them at all. They're like, oh,
whatever. I had kids. Like
Right.
I lived through that. I'm good.
Some women, they go to take the groceries out of the trunk and here it comes.
Okay.
I would say that's not normal.
No.
And there's a lot of things that we can do to kind of help with that. And it runs the full spectrum from as minimally invasive as pelvic floor physical therapy, where you actually work with a pelvic floor physical therapist
Sure.
to try and strengthen that musculature, to something called a pessary, which is a medical grade silicone device that sits in the vaginal canal to keep things kind of pinched shut.
Okay.
All the way to as invasive as surgery.
Okay.
And that is something that I do pretty routinely. A lot of times you'll hear about the commercials on TV. Do you have vaginal mesh? Sue this person.
Yeah, I never knew what that was, but
We don't really do that
call
traditional-
James Sokolov
Yeah.
today.
We don't do that traditional vaginal mesh anymore because that was a pretty bad deal. We still do what's called a tension-free vaginal tape or a bladder sling. Some people have heard of bladder sling as the colloquial term. It is a piece of mesh. It is possible that you get those erosions that you hear about on the commercial. It's very, very uncommon, very, very rare, and it's a super effective procedure to help you stay dry.
Okay.
It is something that I do. Most of my partners are send their patients to me for that.
Okay.
But there's no reason you have to be wearing a pad or a diaper all the time.
Yeah.
There is hope.
There you go. And I did want to talk about that because that's, it's the old girl, like it's like the inside joke between women of, oh, shoot, don't make me sneeze or don't make me laugh because bad things are going to happen. But I like that you said it's not normal, but it's common.
Yep.
That's okay.
Yep.
Makes you feel a little bit better anyway. All right. Well, very good. And this has been such a great discussion.
Yeah.
We thank you for coming in and spending the morning with us.
Absolutely. I told you I could ramble for an hour.
Hey, no, that's good. He did real good, didn't
Only
he,
getting
folks?
started.
No, would you come back and see us sometime?
Absolutely. I'd
And
love to.
we really enjoy having you here and talking about all of these women's health issues because they are important. At the end of the day, ladies, just take care of yourselves.
That's right.
Do what he says, please. And he's so sweet. Give him a call. Say, I want to see Dr. Bowers.
Yeah.
Because he's fun.
That's
and he
right.
plays really good music in the delivery room.
That's right.
All right. Well, very good. Thank you for spending your morning with us. And we thank you all for tuning in. And I guess we'll be back here tomorrow. So have a great day. Enjoy some beautiful weather.
Yeah.
It's going to be great.
For sure.
We'll see you back here tomorrow. Bye, everyone.
This just in.
The Telegram News has a new website.
thetelegramnews.com.
Same dedicated coverage.
Same trustworthy news with a brand new look.
Covering Jackson and Benton counties and surrounding areas.
Locally owned and operated, theteleGramNews.com has its finger on the pulse of the community.
Stay up to date on local events, high school sports, and breaking news.
TheTelegramNews.com.
Subscribe today at theteleGramNews.com.
Check it out.